Hi, good morning. I'm Dr. Gaurav Neopane. I'm your new associate professor in the Department of Orthopedic Surgery, and today I'll be taking around a very important topic clinically as well as from your exam point of view, which is fractures around the elbow. So mostly I'll be talking about elbow fractures occurring in children because it is quite common injury among the children. So quickly, we'll be discussing about introduction, the anatomy relevant to the elbow, as well as to differentiate how to differentiate a child X-ray as compared to an adult X-ray, because there are some confusions. And we'll be talking about common injuries ranging from soft tissue injuries to dislocations, fractures, and fracture dislocation, but we'll mostly concentrate on supracondylar and lateral condylar fractures. I'm happy to answer your questions, but make sure that it is towards the end of the lecture. And as we go on, if you miss something, please don't worry much about it, because we'll be talking about these things again and again later on in your clinical postings. Yeah, so I think we're good to start. Yeah. So as we see, this childhood fractures around the elbow, that is a quite common injury in the children of a school-going age group, because the children are inherently very active, very outdoors, and having activities such as running, cycling, jumping around. So because it's an actively growing area around the elbow joint, so there is a high rate of bone turnover. So it is a potentially very weak area. So it gets quite easily injured when you sustain a fall. And these fractures are important because they are associated with neurovascular complications. Yeah. So briefly, let's talk about elbow joint anatomy. It's composed of three bones: the lower end of the humerus, the upper end of the radius, and ulna. So that forms three joints around the elbow joint, which is the articulation between the radial head and the capitulum. So that is called the radiocapitular joint, and the ulnotrochlear joint, as well as the radius and ulna. They articulate with each other in the proximal end. So that is a proximal radioulnar joint. Yeah. So the elbow is quite a strong structure, which is supported by bones as well as strongly supported by ligaments. The ligaments of clinical importance are the medial collateral ligament on the medial aspect of the elbow, and the lateral collateral ligament, which is composed of radial and further ulnar collateral ligaments, which add to the stability of the elbow joint. So in case of elbow dislocations and injuries, it's not only the fractures, but if the ligaments get injured, it's potentially unstable injury around the elbow and having long-term consequences. So let's see this X-ray of the child as well as the adult compared side to side. So we need always two views of the X-rays, the AP and the lateral view. And in the first two X-rays, that belongs to the child. So don't confuse that fracture, those radiolucent lines to be fractures, because most of the people, they tend to get confused with the fractures, because these are really the epiphyseal, the growth plates around the radial head, around the capitulum, around the medial epicondyle. So this is essentially a normal X-ray of the child. If you see on the left-hand side, on the right-hand side, it's the growth plates, they have already been fused, so it's a mature adult X-ray. Yeah. So it is always useful to know this mnemonic, CRITOE, CRITOE. So which tells you around the approximate age of ossification that occurs around the elbow. So it's roughly, capitulum starts at 1 year, and as you go subsequently, if you add 2 years, there is the ossification of the radial head, the medial epicondyle at 7 years, trochlea at, medial epicondyle at 5 years, trochlea at 7 years, olecranon at 9 years, and lateral epicondyle at 11 years. These are approximate, but this is just a guide to let you know that looking at the X-ray, let's say if you are looking at an X-ray of a 1-year-old child, you don't expect to see the other structures such as radial head, in medial epicondyle, trochlea, olecranon. They are not still formed. Yeah. So this is just a rough guide. so that you know what to expect in a child X-ray depending on the age. So before going to specific topic, let me just tell you briefly about these two radiologically important lines. So these are always, please note that these are always on the lateral view of the X-ray. Yeah. So these are the first one. The first X-ray shows, you know, that's the long axis passing through the radius. This is the radius bone. So it should cross through the center of the capitulum. So this is the capitulum bone. This is the center. No matter what degree of flexion it is, it should always pass through the center of the capitulum. So anything above or below, you note that the, you know, the radial hair is subluxated or dislocated. Yeah. So the other line is the anterior humeral line, which is drawn through the anterior humeral cortex. As you go on passing it down, it should also pass through the center of the capitulum. Yeah. So anything behind or you know, if the capitulum is quite anterior or quite posterior, then you know that it is a displaced fracture of the capitulum. I'll show you later on. Yeah. So these two lines on the lateral view. Also, the third angle that you should know there is the Bowman's angle. That is actually the angle subtended by, you know, the base of this is the capitulum. So this is the growth plate of the capitulum. If you draw the plane of that capitulum with the long axis of the humerus, this angle, some call it Bowman's angle, but it is quite a confusion because it's an old concept that this is no more about Bowman angle. So the Bowman angle will be if you draw a perpendicular line to the long axis of the humerus, such as this, and this angle between the perpendicular to the long axis of the humerus and the line by capitulum, this 90 minus alpha is actually the Bowman's angle. So that ranges from about 10 to 20 degrees. Yeah. So which is more evidently shown on this picture. So if somebody asks you Bowman angle, you should make sure that you say it's about 10 to 20 degrees and it's an angle between the line subtended by capitulum and perpendicular line to the axis of the humerus. Yeah. So why these lines and angles are important? Because in childhood fractures, the aim of the treatment remains on restoring these lines, because anything, you know, abnormal from these lines will give you a deformity of the elbow. So quite logically, you know, the common injuries around the elbow are just based on anatomical reason. Let's say I'm dividing this further into lateral and medial areas and the bisector of the humerus. So any fractures occurring above these are the condyles. Any fractures occurring above the condyle in this region is the supracondylar fracture. Supra is above, condyle is condyles. Yeah, supracondylar fracture. If it is occurring around the lateral condyle, so that's a lateral condyle fracture. If it is in the medial condyle or epicondyle area, that's a medial epicondylar fracture. If the fracture line is passing through between the two condyles, that's an intercondylar fracture. There can be fractures of the olecranon, the radial head or neck fractures, the Monteggia fracture dislocation, which you guys will be knowing shortly later on in subsequent lectures, and elbow dislocations. Yeah. So just quick X-rays, just to let you know, how problematic these childhood fractures can be. So this is the fracture of the medial epicondyle. This is the medial epicondyle, which was supposed to be around here. So that has fractured and gone inside the joint. So it's quite practically trapped inside the joint. So that will cause limitation of range of motion unless you take it out and fix it back. Yeah. So this is another fracture. You can see the capitulum here. You can see the capitulum here. The trochlea ossification is there. That's the medial epicondyle. So this is an undisplaced fracture of the lateral condyle and displaced fracture of the medial epicondyle. And here, by this X-ray is essentially normal on the AP view. Yeah, it is grossly normal. But as you go on looking on the lateral view, see that's the importance of having two views. So you can see this capitulum being lifted up, which cause limitation in the flexion of the elbow. Yeah. So this is another one, the fracture of the olecranon, which is corrected after surgery here by putting K wires. So this is a frank elbow dislocation. This is just dislocated out of the joint where it was supposed to be. And along, again, that line, yeah, remember that line I told you? So if you draw the long axis of the radius, it passes way above the capitulum. It should be around here. So you see that the radial head is dislocated here, yeah, although the ulna is still there. So this is a Monteggia fracture of the upper third of the ulna with the dislocation of the radial head. It should have been here, yeah, just to make you familiar. So why is this elbow injuries important? There are many clinical implications, such as, because it's a growing area, you can actually have malunion or non-union, leading to, all these kind of deformities, such as cubitus varus, which is reduced carrying angle than the normal, or cubitus valgus, which is exaggerated carrying angle. Yeah, so it is quite deformed elbow. The tardy ulnar nerve palsy. Tardy means slow. So if there is ongoing deformity progressing like that, so there will be stretching of the medial side with the ulnar nerve, so it will cause a slow, gradual onset of ulnar nerve paralysis, yeah, leading to claw hand. So that is known as tardy ulnar nerve palsy, which is very important clinical entity. And during these elbow injuries, because there are quite significant nerves around the elbow, if they are permanently injured, it leads to clawing of the hand and all those deformities. And as a consequence, this guy is having a cubitus varus kind of deformity in the adulthood as the bone is growing. And occasionally the brachial artery is also injured. So it leads to immediately compartment syndrome, and subsequently as it grows, there will be ischemia of the muscles, leading to shortening of the muscles and tendon, and giving to this kind of hand deformity, which is known as Volkmann's ischemic contracture. We'll be having separate lectures on this. Yeah. So yeah, going to supracondylar fractures now. Yeah, I think you should pay a little bit of attention to these specific topics. Till now, I was just talking about general fractures. Yeah. So by far, this is the most common elbow fracture of childhood. You can blindly say what is the common elbow fracture or common fracture of child. You can say supracondylar fractures very safely. Yeah, so this is that common. So every other child that comes to emergency invariably has some injury around the elbow, and mostly supracondylar fracture. So it's quite peak in the age 5 to 7 years. That's the school and preschool age, where they are most active outdoors. And as I told earlier, so because this is an actively growing area, and there is this active bone formation and resorption going on around the metaphysis, so it's a relatively weak area. And whenever there is fall on outstretched hand, the elbow tends to go into hyperextension, so that quite easily breaks the bone at the supracondylar area, where it is a thin plate of bone. Yeah. And supracondylar fractures are often associated with complications, as I told you, with either with vascular complications or neurologic complications, or even with massive swelling, and sometimes they tend to be missed if not looked at properly. So supracondylar fractures are quite an orthopedic emergency. You need to act early and act properly. Yeah, and if we treat it properly, the outcome is really good, and then the patient won't have any consequences of late complications such as malunion, non-union, the nerve or vessel injuries, or things like that. So invariably for any upper limb injuries, the mechanism of injuries always fall on outstretched hand. F-O-O-S-H, push, as they say. You can safely say fall on outstretched hand, and that can cover actually any mechanism of injury. Yeah. So looking at this first picture, the child is falling down with his elbows extended. He's falling right on the ground with two hands. So as he lands on the floor, it will invariably cause hyperextension at the elbow. So that tends to give you a supracondylar fracture. Yeah. So the other mechanism for supracondylar is, although rare, it can be fall on flexed elbow, as in this child. Note that his elbow is flexed. So why I'm telling you is that this kind of fall pattern gives you a different pattern of fractures. I'll show you later on. Yeah. And there can be sometimes twisting and rotational injuries, as noticed with child abuse, physical abuse, and battered baby syndrome, etc. But the most important ones are fall on outstretched hand with elbow hyperextension and fall on the flexed elbow. Okay? So as with any fractures, the child presents with significant pain around the elbow. Yeah, there can be sometimes significant swelling, and or sometimes there can be subtle swelling with painful range. Deformity, if it is a complete fracture like this one, then yes, obviously the child will have a kind of S-shaped deformity around the elbow, but unless this is not present in all the cases. Yeah, so the mostly the presentation is painful swelling around the elbow. Yeah, and crepitus is the grating sensation of the bones, the fractured bones when they rub against each other. So that can be felt by the child as well as the parents or whoever is handling the fracture. If there is associated neurovascular injury, there can be evident ecchymosis, as you see on the anterior aspect of the elbow. Yeah, the bluish discoloration there. And sometimes if the spikes around the fractures bone, if that gets impinged inside the muscles, that tends to pull the muscle inside and cause a dimpling around here. So that is an indicative of a muscle being tethered inside by the sharp spike of the bone. You need to be very, very careful to disengage, because these sharp spikes, as the brachial artery and the nerves, they are just right here. It has a potential to get damaged by these sharp bone spikes. Yeah, as told with the mechanism of fall, as you can note that extension type is quite common, because invariably by the mechanism of fall in an extended elbow and hyperextension of the elbow joint causes this type of fracture. So it is quite common mode of injury, and it results in this type of fracture where the distal fracture is displaced posteriorly. Yeah, so this is known as an extension type of supracondylar fracture, and less commonly, only about 2% when the child is having a fall on the flexed elbow, that tends to give this pattern of supracondylar fracture. Although this is also a supracondylar fracture, but the fragment as compared to here, it is gone anteriorly here in the flexion type and posteriorly in the extension type. So this is most common kind of fracture. So you have to remember one name, Gartland. He gave the classification of the supracondylar fracture. So it's basically very simple: type 1, 2, 3. Type 1 is undisplaced fracture, where the fracture, there's a fracture occurring, but it has not moved out of its place. You can see the anterior humeral line; it is still aligned. It is not angulated either anteriorly or posteriorly. So it's basically an undisplaced fracture. And sometimes here you don't appreciate the fracture line, but you can actually see a fat pad from the posterior olecranon fossa. So that is known as the fat pad sign. The fat pad is raised by the hemarthrosis, the blood collection inside the joint that lifts the fat pad up, and that is also a sign of supracondylar fracture undisplaced. So you need to treat this as a supracondylar fracture, even if you don't appreciate distinctive fracture line in the X-ray. Yeah, you'll realize it more in your clinical postings there. Yeah? So these are invariably treated conservatively with just plasters. Yeah? Type 2 are a little unstable fractures where it is a displaced or angulated fracture. But the essential thing is that the posterior cortex and periosteum should be intact. So you can note the fracture is occurred here. It is angulated posteriorly. The cortex is discontinuous here, but there is some cortical contact here, as well as the periosteum sleeve will be there. So it is totally not displaced out of its contact with the proximal bone. Yeah. So this tends to be midway. This can be either treated conservatively with a plaster, after getting close reduction, but sometimes this can slip. Sometimes it will require percutaneous spinning, operative intervention. The third important one is the complete displacement of the fracture. So you can see with this X-ray, there is absolutely no cortical contact between the two. So it is displaced posteriorly. Yeah. So this is further subdivided into 3A and 3B. 3A is medial displacement and 3B is lateral. And among all, 3A is quite common. Yeah, medial displacement of the fracture. So you talk in terms of the distal fracture. So let's say this is the distal part of the fracture. This is the humerus. So this distal fragment is going medially towards the ulna. Yeah. So this is posteromedial. Yeah. So this is an extension type of supracondylar fracture that is displaced medially, not laterally, because you are talking in terms of the distal fragment in relation to the proximal. So the potential complications are injury to the nerves, very common. As you tend to fall, there's this median nerve branches, anterior interosseous nerve and posterior interosseous nerve just right by. So quite commonly injured is the median nerve, the anterior interosseous nerve division, that's the median nerve. So when you ask the patient to make a OK sign like that, the patient is unable to do. The patient will make something like that instead of making a perfect OK. Yeah. So that's the sign of a median nerve injury. Or if you ask the patient to clasp a finger, the patient will be unable to clasp the index finger. So that is a sign of a median nerve injury. So if you have an ulnar nerve injury, there will be weakness of, abduction, adduction of the little two fingers, yeah, and the subsequent clawing in later stages. And radial nerve is the least common to be injured. So the commonest nerve injury is median nerve followed by ulnar nerve. Things to note. And another injury is commonly to the brachial artery, especially when it is jutting out the sharp spike of the fracture, causing obstruction or rupture of the brachial artery. So that can eventually lead to immediately compartment syndrome because there's a massive bleeding ongoing around the elbow and forearm. And subsequently, as the muscles, they go ischemic changes, it leads to ischemic contracture of the forearm, as I told earlier. So the treatment is aimed at restoring the fracture anatomy to its original position, where your anterior humeral line falls in its normal place, the lateral axis through the radial head falls into the center of the capitulum, and Bowman angle is restored so that there is no valgus varus deformity. So whatever the treatment, the aim should be to restore its normal anatomy. That should be a line. So let's just talk about non-operative treatment. Here you can see the posterior slab extending above elbow is being applied to the forearm, the upper limb. Yeah. So once that is applied and it is forced into hyperflexion. So this is quite hyperflexed elbow. So you know why that is being done, because there is this triceps tendon there. So if you are immobilizing in this position, there is less chance of the fracture being displaced posteriorly. So it will be locked in that position to allow it to heal in that position for about maybe 3 weeks, where the soft callus will grow, and then eventually you can just remove the plaster and start mobilization. Yeah. So this is just applicable for grade 1 or some say grade 2 fractures, type 2. So as we go on unstable type 2 fracture, if it is displaced or if it is type 3 fractures, which is completely displaced, then it is always safe to take the patient to operation theater and do a close reduction and percutaneous spinning. This is performed under anesthesia. It's quite relatively a short procedure, quick procedure. And as you palpate the median nerve, you insert this kind of a K-wire, as we call is K-wire. The full name is Kirshner wire. So that is being drilled, one from the medial condyle and one from the lateral condyle. So it gives a quite stable fixation there. So you put the child in a plaster for about 3 weeks, and after 3 weeks, you just take the plaster and pins out and start mobilization. It's quite quick and good recovery occurring after that. So if it is not possible to get reduction by a closed method, so that is by without opening the fracture site surgically, then you need to do an open reduction and internal fixation. So you need to open the fractures, clean out the fracture in, take out the interposed tissues, put the bones together, fix it with K-wire, and close the wound and apply plaster. Yeah. Sometimes, additionally, when there is nerve and vessel injuries, you have to be prepared to repair the vessels as well as nerve. Yeah. So the CRPP, the close reduction percutaneous pin, the pins can be fixed in any. That's actually a surgeon's choice really. So it can be either crisscross, the crossed K-wires. It can be laterally placed divergent K-wires or laterally placed parallel wires. These two are actually done to avoid the the ulnar nerve injury, because the ulnar nerve, sometimes there is a chance of, this is a blind procedure, as you go through this epicondyle, there's a chance that you can injure the ulnar nerve iatrogenically. So if you are scared about that, it's always safe to put two lateral condyle pins and divergent as well as parallel. Yeah. So post-operatively, we check for redisplacement of the fracture, because that can occur. The child is restless, and you can always have a redisplacement of the fracture. So that needs to be checked by weekly X-rays being done. Check the neurovascular status immediately post-operatively. As soon as the child gains consciousness, ask for the patient to move the fingers just to check that you have not injured additionally any ulnar nerve or any other nerve during the surgery. And as well as it needs to be checked on a weekly basis till the union there, because sometimes the pin can cause pressure on the nerve, leading to slow ulnar nerve injuries, as well as the vessels. Yeah, by checking the pulse. So you should occasionally check the wound and pin site at least at a week's time, because that is also important. You don't want to end up with infected pin site by the time the fracture heals. Yeah, and check bony healing at approximately 3 weeks. We do it at 3 weeks. If there is visible callus around, you just get rid of the plaster, take out the pins, and start mobilizing, and that's a road to recovery. So the long-term complications associated with supracondylar fracture, the very important one is the gunstock deformity. That's the cubitus varus, because this looks like a gun, the gun being loaded there. So that's called a gunstock deformity, cubitus varus. So please note that it's a very tricky MCQ question also. So supracondylar fracture is associated more commonly with cubitus varus, and lateral condyle with cubitus valgus. I'll tell you why. And the other complication can be Volkmann's ischemic contracture if there is associated brachial injuries and leading to this kind of shortened tendon and ape kind of hand deformity. If there is an ulnar nerve injury, there can be a clawing of the ulnar 2 digits there, as supplied by the ulnar nerve. And if there is an injury of the median nerve, it leads to ape hand deformity. Okay, so that covers much of a lateral condyle, supracondylar fracture. Now coming to lateral condyle, it's a quite small topic there. So this is second most common fractures occurring after supracondylar fracture. So supracondylar being the commonest, and lateral condyle fracture are the second common fractures of childhood in the upper extremity. Yeah. So again, the age group is almost the same, about 6 to 10 years, where the children are quite active and outdoors. This is also a very unstable fracture, because it's also known as a fracture of necessity. Why? Because it invariably needs to be opened and properly fixed by surgery in order to heal properly. Because it's actually a growth cartilage and quite a significant chunk of the growing bone. So it needs to be anatomically fixed. So lateral condyle fracture has detrimental effect on growth on the elbow, because it itself is lateral condyle is actually composed of capitulum and its growth plate. So it has its role on the growth on the lateral side of the lateral part of the elbow. So if it is injured and if it does not grow, then only your medial side of the elbow grows. So that leads to, the cubitus valgus kind of deformity. So that's the reason you have cubitus valgus deformity in lateral condyle fracture, as the lateral condylar part does not grow. So it's broadly classified by Milch, very easy classification, just two types, type 1 and type 2. But you should be knowing what is type 1 and type 2. Type 1 is the fracture line, which is just extending to capitulotrochlear group. So this trochlea is intact, capitulum is intact, but the fracture line is just passing right through. So it's a small chunk there, yeah. Whereas type 2 is a more bigger chunk of the fracture. So the fracture line actually goes from there, goes further medially and involves part of the trochlea, yeah. So if this is involved, so this is quite a large chunk and very, very unstable to the elbow. It needs to be fixed anatomically. If it is not fixed properly, then we'll have, consequences of deformity, flexion of the elbow, restriction of the motion, stiffness, etc. So type 2 is more common. So, because the unstable type is most common, it invariably needs open reduction and surgical fixation. So again, the mechanism of injury is fall on outstretched hand. So this time when the child lands on the force, there is no hyperextension, but in supracondylar, it was hyperextension of the elbow as the child was falling on the ground. But here, it is when the child is falling on an extended elbow, there is a varus force, such as twisting or something hitting on the outside of the elbow, leading to lateral condylar fracture. So yeah, the swelling is there, but definitely a little less as compared to supracondylar fracture, and the swelling is limited to the lateral aspect of the elbow. Yeah, because of the pain, the child is unable to flex the elbow. There will be painful restriction of motion. There can be deformity, as in this one, because of the swelling, but it's not essential that it should be there, and deformity is not as pronounced as it is in supracondylar fractures. And because there are no nerves passing around, actually, on the lateral border, there's a less incidence of nerve injury associated with lateral condylar fractures. Just a quick X-rays to show you around. This is the capitulum. This is the, you can see the flake of the bone there. So that is a partially displaced lateral condyle fracture, whereas this one is a totally displaced lateral condyle fracture. That you can see the capitulum, the condyle actually is coming out and rotating. That this part should have been here, and this part should have been here. So this is quite unstable and bad-looking fracture. And I'll tell you one thing, because it's composed entirely of cartilage. When you open it, the chunk is actually much, much larger than you see on the X-ray. So let's say if you see on the X-ray, a very small chunk there, but as you open, because it's cartilaginous, it's quite a significant chunk there. So that can be adequately fixed to give a normal appearance of the elbow, just restoring the anatomy of the capitulum, thereby preventing further injuries. Yeah. So as I told you, just remember that lateral condyle fracture is a fracture of necessity. Why? Because it needs open reduction and fixation, surgical intervention immediately in order to correct. So this can be fixed by either the same K-wire configurations, because the advantage is just you can just pull it out at the end of 6 weeks, after the healing occurs. Or you can also use screw, kind of an internal fixation device. This usually comes out at around maybe 6 months or later. So rarely there is a role for non-operative management in lateral condyle, because if it is hardly undisplaced, then only you tend to immobilize in a plaster or just in situ percutaneous fixation, but that is quite rare. Most of the lateral condyle fractures, they require surgical intervention. So that can be either close reduction, percutaneous pinning, yeah, or open reduction and pinning with either K-wires or screws. Yeah, K-wires and Kirschner wire. The full form of K-wire is Kirschner wire. Just to orient you. You'll be knowing about it later on subsequently. Yeah. So this picture shows about long-term complications of the lateral condyle fracture. As you can see, malunion is most common with supracondylar fracture. Non-union is common with lateral condyle fracture. Please note that. Yeah. So because it's a cartilaginous portion there that has not united, so there is this non-union portion of the lateral condyle. So as you can see, only the medial part of the elbow has grown. The lateral part of the elbow is not growing. So the patient is having cubitus valgus deformity. Just note the left elbow of this lady as compared to the normal one. There is increased carrying angle as compared to this one. So there is this consequential deformity, the cubitus valgus. So as I told earlier, as this deformity goes on increasing, the nerve around the medial aspect of the side, that's the ulnar nerve, goes on stretching. Yeah. So as it stretches over a long period of time, it will cause ulnar nerve palsy, leading to tardy ulnar nerve palsy. That's that. Tardy means slow. Slow ulnar nerve palsy occurring in cubitus valgus as a consequence of lateral condyle fracture. So as the ulnar nerve palsy sets in, there is this ulnar clawing and all this atropic hypothenar eminence and weakness in adduction, abduction, and all those clinical signs you'll get. So the treatment will actually be doing a corrective osteotomy of this elbow, make the elbow angle corrected to approximately the opposite side, and transpose the ulnar